Good afternoon, everyone. I'm so excited to welcome you all here, and with a little bit of better planning, we probably could have done some different things, but it is just fabulous to have so many people here to hear our discussion about this extremely interesting and exciting topic, the science of healthcare delivery. So this afternoon, I'm very pleased to be able to introduce you to Dartmouth College President Yong Kim and Dr. Al Mulley, who is the recently appointed director of the Dartmouth Center for Healthcare Delivery Science. And they will be joined by our very own Dr. Jim Weinstein, they will all three work together to talk with us about the science of healthcare delivery. Now, as I say that phrase, healthcare delivery science, isn't it fabulous that this is what we do every day? We are immersed in the delivery of healthcare, and I really like to believe that because of the work that each and every one of you does every single day, we are leaders in healthcare in the United States, and it is through the work that you do and through the advances that we've made that we're able to partner with Dartmouth College and bring to life the Center for Healthcare Delivery Science. So we are the laboratory, and we are going to be participating in this every step of the way as we have through its inception. It is extremely exciting for us to be able to showcase some of your work, shared decision-making, our quality and safety programs, the excellence in care that our physicians and nurses and all of our staff are engaged in every single day. And indeed, our very mission, providing the best care in the right place at the right time, every time. This is the essence of healthcare delivery science, and it's what we do at Dartmouth-Hitchcock each and every day. So we're thrilled to have this center as part of our community, and we're thrilled to be a part of it. And I'd like to just give you a little lay of the land of how we'll conduct the session this afternoon. So we'll start off with President Kim giving us an overview and some remarks. And then Jim Weinstein will follow, and he'll talk with us in more detail about the science of healthcare delivery. And then we'll have plenty of time for questions and answers. And you see those three chairs up in the front. Dr. Mulley asked me to announce that the one with the back belongs to him, and his two colleagues can have the stools. And they will all be seated in the front, and I'll help moderate the questions. So as Dr. Kim and Dr. Weinstein are talking, be sure and write down your questions, and we'll have lots of time to have a dialogue. So without further ado, Dr. Kim, welcome, and thank you for being here.
Thank you. Thank you. It's a great honor to be here, and I am just the warm-up act here. And all I wanted to do, and I apologize to those of you who've heard pieces of this before. I just want to start off by giving the rationale, my own rationale, and thinking about why Dartmouth has such an important role in healthcare delivery science. I think that the relationship between Dartmouth College and Dartmouth-Hitchcock Medical Center is, in fact, the critical nexus for taking healthcare to the next level. We've had some very exciting meetings. There's lots of exciting things that are in the works. But I wanted to start with my work in developing countries to give you a sense for why I think that this is so critically needed. You know, we started the Dartmouth Center for Healthcare Delivery Science less than a year ago, and since we announced the center, there have been, I think, 5 other institutions that have announced their own centers for healthcare delivery science. Cornell was the first, then McGill, then Mayo Medical Center, and then Stanford, and there's one more that I can't remember. But these are all right on the heels of us declaring that between the 2 institutions, we were going to launch the field of healthcare delivery science. I agree with Nancy. You do it every day. But there are things that we can do to bring the science together with the subtle and difficult and complex understandings of how you run a social organization, with a model for how to take great practice that does what's right for patients at a lower cost and at higher quality. We think we can take that model to the rest of the country. You know, we were just in a meeting, and one of our colleagues was saying that he thinks that healthcare is the biggest financial and business problem for the world today. Maybe not the most important problem for the world today, but I can tell you every country in the world is facing a problem of trying to figure out how to structure their healthcare system. I have never been in a single country that doesn't face this problem, from Haiti all the way to Switzerland, where I lived when I was working at the World Health Organization. So let me start by just giving you a little bit of the rationale for healthcare delivery science from my own experience, and then hand it over to Jim. So for 25 years of my life before I came to Dartmouth, these were the places that I worked with an organization called Partners in Health. For a 3-year stint, I worked at the World Health Organization, first as the senior advisor to the Director General, and then in heading up the HIV department. But these were the kinds of places that we tried to grapple with this question of how do you organize healthcare services in a way that will be low cost, high quality, and that will truly serve these populations. Let me just give you a particular example that's really kind of off the charts in terms of the disease that we took on, but is illustrative of what we found we needed to do to be effective in settings like this. This is a squatter settlement in the northern cone of Lima, and you know, from Upper Valley standards, it looks very poor, but this happened to be the wealthiest area that we worked in developing countries, and the reason you can tell that is there are electrical power lines and also water. So it's a relatively advanced community given what we had been dealing with, but what we found in this community was a very complicated problem, multidrug-resistant tuberculosis. And in 1996, when we started working in this area, the conventional wisdom and the wisdom that the World Health Organization pushed very strongly is that drug-resistant tuberculosis is too complicated and too expensive to treat in those areas. Now, you know, this 1996 was before Bill Gates' investment in global health. This was before the President's emergency plan for AIDS relief that President Bush put into place in 2003, and there was just no money for healthcare. So it was the most rational argument to make. There's drug-resistant tuberculosis spreading very nicely, thank you, in a community of about 100,000. We found 50 cases in the community of 100,000 just right away. And so if you do the numbers, the number of cases in the United States, you know, varies between 5 and 7, maybe 9 in really bad years. Cases of just general tuberculosis in a population of 100,000. We found 50 cases of drug-resistant tuberculosis in this town of 100,000. In the context of probably 500 to 1,000 in any given year of overall cases of drug-resistant tuberculosis. We found that it was clustering in families. In other words, it was being transmitted from family member to family member. And we broached the issue of, well, what do you do? What do you do in situations like this? And the answers were very clear. You can't do this because it's too complicated. You can't do this because the nature of the healthcare system is not up to par to be able to tackle a difficult problem. Any of you who've treated drug-resistant tuberculosis know that it's one of the most difficult problems to treat. It's a minimum of 12, but usually more like 24 months of treatment, usually with an injectable of some sort for 6 to 7 days a week. And the injectable you have to give for, again, up to 12 months of the treatment course. The reason that the treatment is so difficult is because market forces have led to a situation where there are no new tuberculosis drugs. There hasn't really been a new drug for almost 35 years. The last time we had a really new drug that was really effective for tuberculosis was rifampicin. Some of the fluoroquinolones are being used now fairly effectively, but we just don't have a market for it. So the reason that it was so expensive and the reason that it was so difficult is we were using old drugs. One of the drugs is para-aminosalicylic acid. Is there anyone who've ever used PAS in this room? So we use it all the time. One of the first antibiotics, and that was one of the things that you have to use among patients. And of course, what we found is that there are no good, or there are only very few good preparations of it, and it causes severe gastrointestinal side effects. The other medicines that we were using, cycloserine, penetrates the blood-brain barrier very easily, so people get psychotic when they take cycloserine. So it was a very difficult treatment process, but we achieved close to 85% cure rates in patients who had been treated for tuberculosis for years and years and years. Their x-rays looked awful. And in the process of doing this, of course, we began thinking about this, that this is not a problem of science. In fact, the science is 35 years old. This is a problem of how you bring a social organization together to tackle something as difficult as drug-resistant TB treatment. I see Mark Israel up here. We're now doing cancer chemotherapy in these settings. Of course, we can't do the kinds of therapies that require negative airflow rooms, but we've done pretty darn well in treating a bunch of different cancers. And the foundation of it for us is that we always went into a situation and built up the basic healthcare services so that it would be capable of handling these kinds of problems. We trained community health workers to specifically go out and give the injections and follow these patients who had side effects so that we could treat the side effects and keep them on the medication. The number one reason that people fail drug-resistant TB therapy is when the side effects hit, what clinicians do is back off on the medications, and then when you back off on the medications are so weak anyway, you begin to lose the battle. So we didn't do that. We used community health workers. And if you've been reading The New Yorker lately, this looks, for all the world, now like a hotspotter intervention. It's exactly what it was. There was a hotspot of multidrug-resistant tuberculosis. We were told that it couldn't be done. We were told that it's impossible to organize the services. The cost of the drugs was also very high. But again, as I told you, these were all generic drugs, and the only reason the costs were so high is partly because WHO said you shouldn't treat it in poor countries. So the Indian and Chinese manufacturers weren't making them because their signal from WHO was only rich countries will use these drugs. And so it was Lilly and little mom and pop boutique pharmaceutical companies that were making these drugs, and the costs were high, probably $35,000 for a complete treatment course for drug-resistant tuberculosis. So we built the system. We did, if you read the New York article from a couple of weeks ago, it looked very much like Ruchika Fernandopoulos' system in Atlantic City, where we had health workers, we had a couple of physicians, but mostly nurses and community health workers. We had high cure rates. And then we understood that the only way we were going to actually push this argument forward was if we also brought down the cost of drugs. Talked to a few companies in Denmark and in the Netherlands that dealt with Indian and Chinese pharmaceutical manufacturers, and we were able to reduce the price in a year 84 to 95%. So where are we now? Well, we've proven that if you use community health workers and physicians and do the kind of outreach that now everyone is talking about in the United States healthcare system, if you do that, you can get very high cure rates. What's happened, though, is that most countries have simply gotten the drugs and tried to sort of surgically attach a drug-resistant TB program on top of an existing TB program. And there have been problems with delivery. And so what I continued to think about was, okay, so where is the science of capturing the things that we did, capturing the things that other countries have been doing to get fantastic results? For example, a group called BRAC in Bangladesh last year had 40,000 cholera patients. And these were patients who were so sick that they required hospitalization. And of the 40,000 cholera patients that they saw, they had 2 deaths, right? So this is just astounding. And we have begun to do some case studies on the BRAC system, and their use of community health workers is just phenomenally good. And once again, if you look at the way BRAC has been doing their work, it looks for all the world like the way that folks like Ruchika Fernandopoulos and Dr. Brenner in New Jersey, have been organizing their efforts to bring down costs by focusing on the highest risk and most expensive patients. So it seemed to me like there were some principles about how you organize healthcare services, principles that focused in many cases around community health workers, but also how you coordinate the relationship between doctors, nurses, and community health workers so that it's more effective. Simple things like this, just bringing a buying pool together, going to India and China, we really, not completely, but 90%, we solved the cost problem in the course of a year. So it's my strong belief that in addition to the sciences that we have now, basic science, clinical science, and evaluation science, all 3 of which are extremely strong here in our community, that we're we really think there's another science. Now, I call it a science in the most aspirational sense. It's not yet something that we would call a science. And I think ultimately we don't want it to be thought of as purely a science. We don't want people to say, well, you know, you can't change your intervention. You have to have a 5-year study, do the same thing over 5 years, and that's the only real data. You know, we do, the healthcare delivery science has to be different. There will be some things that follow sort of classic scientific methods. But there's all kinds of other things that we need. We need to capture the hunches, the notions that have helped health systems work effectively. We need to make sure that physicians, nurses, and other health workers can have a career in healthcare delivery science so that all they're thinking about every day is what can we do to improve the quality, do what's right for patients, lower the cost, and get us on a path where we're going to be just focused on doing the best that there is for patients and take us in a direction that will be helpful not only in the United States, but it is my firm conviction that if we build healthcare delivery science in the United States, there will be huge benefits for people in developing countries for a lot of different reasons. And I think one of the reasons is going to be purely out of self-interest. You may know Vijay Govindarajan at the Tuck School of Business, and Vijay has been the Pied Piper for something he calls reverse innovation. Vijay thinks that for American businesses, there's a lot to learn from what's happening in developing countries. And I would argue that before the hotspotters came up with their approach, the best healthcare systems in developing countries were doing exactly that, not necessarily because they thought it was cool, but because it was the only option we had to use community health workers to work with doctors and nurses to provide the best care. So let me just say that we're in the early stages still. I just show you these because we began working with Professor Michael Porter at Harvard Business School, and we have begun the process, in global health anyway, of engaging in the observational phase. We need to capture those great experiences that might be helpful. Now, you know, again, this might not conform to the standard sort of, NIH-style study, but what we need to do is capture the intelligence, the insight that's already in the field about how to organize healthcare services more effectively. It's going to start with case studies, but then we'll be able to generate hypotheses and, taking a page out of the work of so many development economists, begin doing what they're calling randomized evaluations. So instead of thinking that you're doing a randomized controlled trial, what they do is they say, well, we've got this chunk of money and we're going to roll out these programs anyway. So why don't we just stutter the rollout of these programs and measure in all the areas from the beginning so that you don't, it's not the quality of a randomized controlled trial, but you get very powerful information about how particular areas change as you roll out a program. The World Bank now is trying to move toward doing all their work in that way so that they get data every time they roll out a program instead of just spending money and waiting 5, sometimes 10 years to get an evaluation that doesn't capture what you've done. All to suggest that healthcare delivery science, in addition to all the great outcomes research that we do here, could bring to the medical field wonderful new methods that are being used in other areas that could help us figure out the delivery problem. We think, as I've said, there's a burning need, but I think there are a few places in the country, and I'd say in the world, that has this combination of a college that is really ready to take on this problem and a world-class health center like DHMC. I think we are the right people at the right time to take this to the next level. I'd also say, Dartmouth Medical School has a long history of innovation, and this was Mary Hitchcock Hospital back then. It was on the campus of Dartmouth College, diagnostic imaging, the first medical house, and of course, the work of healthcare delivery science builds so much on the work of Jack Wenberg and the Dartmouth Institute and the Dartmouth Atlas. So the center, I think, is poised to do great things. I think that we're ahead of many others, but it's striking to me that we make an announcement and within 9 months there are 5 other centers. I think part of the realization is that there is going to be huge amounts of money coming out of the government and other funding agencies to figure out how to reduce costs and improve quality. I think that's absolutely true. There's a $10 million innovation fund, and we're in heavy discussions with that group already. But I think that every company in the United States is saying, oh my God, I'm growing at 9% a year in my costs. If you can do anything to help me, here's how much it would be worth. Right? So AT&T spends, how much, Jim? $6 billion a year? $6 billion a year on healthcare, and they're growing at 9%. So how much are they willing to spend if we can cut their growth from 9% to 7%? Every single company is doing that. Here's the thing. McKinsey, Bain, all of them are trying to get into this business. But they don't have what Nancy talked about. They don't actually do it. They don't have the means of studying it. They don't have the insights that come from actually running a great hospital. So I think we're poised to do this. I think it shouldn't, I hope you don't see this as simply a risk to the way we've always done things. You know, Wayne Gretzky always says, let me go back one. You know, Wayne Gretzky used to say, good players play where the puck is, great players play where the puck is going to be. Right? I think this is where the puck is going to be. And I think we are ahead, but I think we have to move, and we have to move quickly if we're going to stay ahead of the game. Now, let me just end with this. Okay, so this is one of our patients in Haiti, he came to our clinic suffering from both tuberculosis and HIV. And because we built the system that first looked at his social situation, looked at his medical problems, gave him medicines, sent him home with a community health worker that managed his medical the intake of his medicines every day. Someone living in this kind of poverty, it's very difficult for them to comply with difficult medication regimens for tuberculosis and HIV. But in a few months, because we had that system set up, because we had what's now called the hotspotter system in place, this is what he looked like. If we can do that in Haiti, just imagine what we can do together here in the Upper Valley. Thank you.
Okay, back to Lebanon. We're so fortunate to have Jim Kim as the president of Dartmouth College. Is this on? Yeah, it's fantastic. And now we have Al Mulley. Lots of people are moving from Boston to the Northeast here and finding where the real action is. And I'm really excited to work with Jim and Al on this. And Al often talks about where is the wisdom in healthcare, and I'd like to suggest that it's here. It's on our campuses, across the campus. And the notion of healthcare delivery science that Jim and I talk about is to bring us together. The wisdom and the cross-fertilization and the new ideas like Rashika and the New Yorker, or many years ago, as Jim and Paul Farmer have done, need to come to Lebanon, Mary Hitchcock, Dartmouth-Hitchcock, and our region to take on the challenges that our country's facing into the future. You're all familiar with the growing healthcare economics. We can't afford this as a nation. I can't imagine going from $2.3 trillion to $4.4 trillion in such a short period of time. What will that do to our economy? What will that do to our system that's already in tremendous debt? You're familiar with the work of Jack and Elliot and others around variation and all these problems that we face in healthcare. The frustration that our patients and you all face in the system of not being able to deliver what we want to do. And we have to think about what we're currently doing to preserve what we do rather than what we need to do to change what we're doing to preserve a better future. This is another article, you know, anything Atul Gawande writes, you ought to read. This was classic work, and the reason I show it, most of you are familiar with it, is because the data comes from here, from Jack and Elliot. And he talked about McAllen being expensive and La Crosse being different, Dartmouth-Hitchcock somewhere a little greater than La Crosse. And I just got some new data from John Skinner actually today where these things actually haven't changed. So despite the debate, McAllen continues on its path. La Crosse, Wisconsin continues on its path. And Atul wrote, here a medical community came to treat patients the way subprime mortgage lenders treated home buyers as profit centers. And some people think of healthcare as a bit of a Ponzi scheme. That's not what we're about here. On the other hand, if we don't think of new ways to manage our patient populations at a lower cost, then are we any better? La Crosse, Wisconsin. The Gunderson Clinic's done an exceptional job, and a culture that focuses on well-being, just as we do, not just the financial health of the system. As Jim mentioned, this is AT&T, a $1 billion cost incurred because of the new healthcare legislation. There'll be a new tax for them. And they're trying to decide whether to stay in the healthcare system or actually opt out, which would actually only cost them about $4.78 million versus the additional $1 billion. So do they let their employees join an exchange, an insurance exchange, and go on their own? Or do they continue employer-based health insurance at more and more expense, which makes them less competitive in the world? These are real issues and real challenges by large companies that are wondering what to do. Jim talked about the science of healthcare delivery. Look at the resources we have in this small community to bring to bear on this. Jim mentioned the business school. We didn't talk yet about the new combined degree program between TDI and Tuck. I know some of you have been in that class, taking some of the classes that are, I think, quite exciting and offer new ways to think about things just in our own community that we're not even applying across the street. We have to learn from each other and do things in new ways. We have to learn from the medical school. Our new dean, Chip Shoba, is very interested in leadership, education, and new models of education. What a great opportunity. The undergraduate programs under Dr. Kim and Carol Folt and others, looking at the way we're going to educate our leaders of the future. How do they participate in the healthcare system, which affects all of our lives? And remember, it's about our patients. So this is Sheila. Sheila is one of my patients that some of you have heard me talk about. But all of you have patients in this room that you could bring up and talk about. And as I talk about care that is important and often not delivered in a healthcare system, I worry about the care that is delivered but not really important for our patients. There's 5 essential things, I think, in healthcare reform that our healthcare delivery science program will think about that are really important. Healthcare has to be safe. One of the things missing in healthcare is measurement. What are we doing? Do we actually know our outcomes? How well are our patients doing? What are our costs? How many of you in the room can actually tell your patient what it costs for the treatment you're offering them today? How many can? None. Informed choice. We started the first in the nation shared decision-making center, now under the leadership of Dale Vidal. What a great opportunity that we still haven't quite taken advantage of locally and nationally. But it's in the new legislation. The delivery sciences, all the things that Jim did in Haiti, we ought to be able to do in Lebanon. A different kind of workforce, managing patients at a lower cost with higher satisfaction from the patients and better care and collaborations. And I'll touch on each one of these quickly. Our safety center at Dartmouth-Hitchcock is only one of 3 in the nation. Under Tom and Nancy's leadership, we started the new center that George Blake is running. What an incredible opportunity for us to practice healthcare delivery science before we deliver healthcare delivery science. What a great laboratory. That improves our quality, reduces our cost, makes things safer for patients, and decreases the errors. This is the center for those of you who haven't seen it and should visit it. And these are some of the opportunities. I understand from George, they've even tested flooring samples to understand what would be the safest flooring to have in a facility or a room. Great opportunities for our medical students, great opportunity for our faculty, great opportunity to work with our community to actually study things before we do them. I often talk about healthcare airlines. How many have flown healthcare airlines? Not too many. How many have had health care? A lot of you. Healthcare airlines is a little scary. It doesn't know where it's going. It doesn't know how much fuel's on board, how many passengers, what altitude it's flying at. So most of us probably don't want to fly it. But because airlines have put in instrument panels that allow them to actually know those things in a remarkably reliable way, we're willing to get on something really big, let it take us up in the sky, and take us somewhere else, and hopefully get to where we're planning going. Imagine healthcare. We don't even know those measures. We don't know what's happening, but we trust the system because of human nature to take care of us. But how are we doing? Dartmouth-Hitchcock did some of the first patient-reported measures in the nation, and now this is going to be part of meaningful use moving forward with work by Elliot and Jean and others. But the Spine Center's done some of this where we have personalized care for the patient. We interconnect with our doctors and other practitioners. We want to inform the clinical practice so that we can learn from our mistakes and do better and not continue to just practice because that's what we do every day and it seems to work, but we don't really know because we don't measure it. And we have to improve population health. Dartmouth-Hitchcock under Paul Gardant was the first to put up some transparency measures. On our website, people can actually go and look at our outcomes. That's a fantastic opportunity. Transparency is missing in healthcare. We need to be transparent about our outcomes and our costs, and we need to change what we're not doing well to make it better. Nothing wrong with making mistakes, but we have to change it. In the Spine Center, we have these results that look really good for spine surgery, and I would tell you, as most of you know me pretty well, that there's too much spine surgery in the United States. And as chairman of orthopedics did quite well. We're one of the better margin places in the organization. And our results are really good, but we operate on the right patients, which is less than 1% of the patients we see. The informed choice we talked about. What an incredible opportunity to engage patients in their decisions about their own health care. Instead of listening to the patients having regret about the mastectomy or lumpectomy or prostatectomy that we hear stories of in the center, they want to participate. They want to work with you. They want to be informed about the complications and drugs before they have the treatment. In some ways, informed choice is about safety. Because if we're doing things that people don't want and they have complications, that's not safe. We've done over 8,000 patients in our shared decision-making center. It's a fantastic place. Most all of you know about it. I'm not sure how many of you have used it. But this is the kind of information that all the doctors would say, because I've been doing this for a long time, I already do that, Jim. I already tell my patients what they need to know. And I'm telling you that you don't. Because we all come by with our own biases and our own beliefs of what we do, and that what we do is what you should have. But what we do is what the patient should know about, and what they should have should be their decision, given the information. This is data on spine surgery for the United States from the Dartmouth Atlas. Stanford needs to have healthcare delivery science, Jim. They're one of the higher spine surgery places. But you know, we're one of the lowest places in the country in the Spine Center under Bill Abdu's leadership now. Fantastic place to work, fantastic place for patients to go. You feel good about it, doing it every day. And we do fine financially. And imagine if we do fine, and that's the rate, what's everybody else doing? They're not seeing different patients than we are. This is a health plan, the same sort of things. And health plans are asking the questions from employers who are paying higher and higher premiums. Should we be doing all this stuff above the line? Assuming that we're right. And the reason I think we're right is because we use informed choice and patients make the decision. Prostate surgery, even in HMOs, Kaiser-like organizations, when you add these tools, capitated systems, rates of procedures go down. There's something to this. We live in this world. It is healthcare delivery, as Nancy talked about. We do it every day. So we have this opportunity, an incredible opportunity to bring all these disciplines together and to work together, as Jim says, under one Dartmouth. That's something we can't pass up. We have to do it. It's an obligation to our patients and our community to do it. Collaborations. Fantastic work by Jerry O'Connor, Steve Plume, Bill Nugent on the national collaboration around heart disease, Larry Dacey. We've done similar things in spine in 11 states. We are people who want to collaborate. As we form more initiatives around healthcare delivery science, Jim imagines there should be 30 such centers, just like cancer centers across this country, so that we can work together as a nation wanting to improve healthcare, not as individuals, not as individual institutions, but as a nation and as a world. And then more recently, we've formed this national collaborative that some of you know about with Mayo, Intermountain, Geisinger, Cleveland Clinic, et cetera, and 30 others. And we're hoping that they'll come together and look at delivery science with us in partnership to change the way care is given. And I can tell you, these organizations are not going to wait for us or anybody else. They realize the environment they're in. They're in the same environment we are, and we have to move, and we have to change. The dream team was written about. They called us, I'm not sure it's a dream team yet. We haven't won anything, but that was the dream team that played basketball with Michael Jordan years ago. And the writer of this said these organizations were part of a dream team. I think we have to prove ourselves. We haven't done that yet. So I can remember Jim Kim's inauguration, which wasn't so long ago, and what's happened here. And I can think about Sheila, the patient. That's what this is about, or Jim's patients in Haiti. So we're honored to have this opportunity. We're honored to work with you. Nancy and I are very committed to these kinds of opportunities. We realize how hard this is because the system wasn't built, as Paul Batalden says, every system's designed to get the result it gets. We've gotten bad results in the system of how we're actually going to move a system forward in a fee-for-service world. We can change that, working together. So thank you.
So ask your question loudly. I'll repeat it, and then our speakers will help us answer those questions. So who has a question? Yes, Mary.
Can you talk, where do we go from here?
We have to repeat it for the camera. So Mary's asking about the timeline for a healthcare delivery science.
Sure. I've been here since November 15th, and it's been an incredible experience for me. It's a privilege to join the leadership team for the new center. But there's a lot going on before. The center was announced in May, and I think it's fair to say that when the first Center for Healthcare Delivery Science was announced at Dartmouth, no one in Hanover said, why Dartmouth? But no one in Cambridge and Boston or New Haven or Palo Alto or anywhere in the country said, why Dartmouth? My point there is that that's testimony to the fact that there are already enormous pre-existing strengths doing the work of the center. TDI being the most obvious, but there are also pre-existing strengths at Dartmouth that weren't being brought to bear fully in healthcare delivery science. And a good example is the TDI faculty.
The microphone isn't on.
A good example, is that better? Thank you. A good example is the TDI faculty working for decades on defining the problems in healthcare, right alongside one of the best business school faculties in the world, the Tuck faculty, without a lot of engagement about trying to define the solutions. So very early on, at the time of the announcement, there was this push to develop a new master's program in healthcare delivery science that brought those two faculties together in an amazing way. Every other Wednesday, about 15 TDI faculty, about 15 Tuck faculty get together and give a presentation to one another and learn each other's frameworks and learn each other's vocabulary and try and define solution sets. So I'm actually answering your question. I'm saying a lot has already happened. This high-value collaborative that was announced 2 weeks ago is another very good example. It gets referred to a good bit as part of the new Center for Healthcare Delivery Science, and it surely will be, as does this master's program. But it's been ongoing. Let me stop there.
We could have called it health delivery science, and that's probably more accurate in one sense. But I think part of it's a political decision, right? And the political decision, for me, the reason I got to healthcare delivery science is I tried at Harvard to really work on developing what we called global health delivery science, because there was so much money going in, and we weren't using it very effectively, and yet there were all these insights, so I started writing these cases and try to get it moving. But what I realized was that the donors don't really care. They don't really care about building the system so that it works effectively. And when I look back at the U.S. healthcare system, there wasn't a healthcare delivery science in the U.S. either, so what do you do? So I think that the driving political force is this sticker shock at how much healthcare is costing. And I think that sticker shock is going to help us to do the right thing by patients, right? And it's really, Medicare, Medicaid has a huge stake in this, and now we've got a person in Don Berwick who understands this better than probably anybody on the face of the earth, one. But two, think of my board members, Jeff Immelt at GE. His costs are growing at 9% a year, and he would kill to have it go to 7% growth a year. Look at John Donahoe, who's the CEO of eBay. I mean, these guys are the ones who are going to push this forward. And so I think that what we need to do is, if we're going to politically get to the place where we're doing just what you're talking about, what we've done in Haiti for years, I think the right sort of rocket to latch our efforts onto is this concern for healthcare cost. That's what's going to drive us, I think, to the place where we want to get to. You look at the greatest solutions. I mean, I recommend everyone read this. What's the title of the article again? Hotspotters, right?
Yeah.
Read that article in the New Yorker, because that's exactly what they've done. And it's all about reducing costs for the casino workers union, right? And each step that they've taken, the casino workers union bosses have given them more leeway. What they're doing is compassionate, person-centered care, literally walking people to appointments, literally going to their homes, making sure they take their insulin. But that's resulted in a 25% decrease in their costs before they've even reaped the benefit of changing disease course. This is just early stuff that they're doing over the last year. So my sense is that those kinds of examples are going to expand. Every company in the country is going to want to understand what that's all about. And I think, again, we have the opportunity not just to tell people about it, we have the opportunity to demonstrate it here for our entire population. And if we do that, that's going to send an extremely powerful signal everywhere in the country.
We were just meeting, Ira, before this meeting. Al had arranged a meeting with Rashika to talk about this model, to see how we might engage in these kind of things here.
Yeah. What the hotspotters have done is taken their primary care portion of the healthcare budget, which is about 5%, and doubled it to 10%. What if we doubled our prevention budget from 1% to 2%? What could we do that would have an impact? We're looking at a wellness program for Dartmouth College. Crazy that we've never done it. It pays back 3 to 4 to 1 every time you do it. But we're trying to look at, well, what if you actually had health extenders or health teachers out there, maybe our students, all over New Hampshire doing this kind of work? What kind of return would you have then? I think that there's really sort of greenfield here. I think we can demonstrate the impact of prevention on the overall health of a population in a way that would be very powerful. I've talked, John Lynch is on our board, Governor Lynch is on our board, and Governor Lynch has expressed that if we do something, he would be very interested in perhaps taking state workers and joining a pool that tried these new approaches.
Just to respond to those two questions and bring it back out to the global perspective. I mean, what we're hoping this center will do is to capture global experience for local design and local improvement. There are a lot of elements of innovation theory. Jim mentioned VJ and VG and Chris Trimble's article on reverse innovation. Everybody who thinks about innovation in that way believes that it applies at least as much, if not more, to service innovation rather than just technology innovation. But what I want to mention is the Declaration of Alma Ata, which was in September of 1978. And it basically said that across the range of wealth of nations, the key to global health is an approach that builds primary care systems that work within the community as well as with individuals. So that's your comment about persons, not just patients are. And I went to China in 6 months before the Declaration of Alma Ata as one of 20 people trying to understand how they had accomplished what they had done. I mean, they had dramatically reduced rates of schistosomiasis, dramatically reduced polio rates, increased life expectancy, decreased infant mortality, and they did it with barefoot doctors and something called the cooperative medical system. Unfortunately, they disassembled it. They ran it from 68 to 78 and then disassembled it because they were turning to the market. And the barefoot doctors were no longer supported in the community the way they were, and they had to begin to sell health care. And that brings me to the other point I wanted to make. You know, it's in this distinction between, are we talking about health or are we talking about healthcare? Well, healthcare is an instrumental good. It's only a good thing if it produces or sustains health. And how many of our patients think of it that way? You know, if I said to any one of you, I'm going to guarantee you tomorrow you're going to be at the absolute top of your game, cognitively, physically, emotionally at noon. Do you want that to happen with or without 8 hours in the emergency room overnight? How many of you would say with, right? So it's, you know, we have to, the reason those two things come together is the Declaration of Alma-Ata, 1978, pointing to 10 years of experience of embedding personal care for individuals in the public health framework. Dramatic success. Why hasn't it been replicated elsewhere? I think the answer is confusion about health care and it being a good in and of itself rather than an instrumental good.
Up in the back, did you have a question? The question was, how does the healthcare reform bill speak to the concepts that we've learned today? Very succinct summary, my question.
I'm not sure that it does, to be honest with you. I think it talks about lowering cost. That's what, you know, it's built on. $1 trillion almost put back into a system to get more people insured. Does insurance mean you have good health or good health care? No. Does having a computer with HIT monies mean that you're going to provide better care? No. Does it deal with the issues that Jim and Al and myself are talking about? Not directly. And I think it's these innovative notions like the hotspotters, or like Jim's been doing most of his life, or Al's comment on China, that says, you know, that's not on the map for healthcare legislation. What it's going to be is unique institutions like Dartmouth with the right leadership that start to make these things real, under the radar, documenting the change that starts to revolutionize the way we're delivering health and or health care to a population, whether it's prevention strategies with the state of New Hampshire or the state of California. Everybody has to find new ways to deliver the kinds of things that really are a social injustice the way we manage it today. It's the system, as I said, Paul's quote all the time comes to me, we built a system to get what we've gotten. We have to redesign that system, and we're going to start that here.
The notion that you're going to improve access is wonderful. I've been working on that all my life, and I think that it did that. It improved access to health insurance anyway. But in looking at, Jim and I together have been, at the White House talking about why they need to invest in healthcare delivery science, and they don't quite get it. They say, "Well, go talk to the folks at NIH." And the folks at NIH go crazy because, but this is not, randomized, and where that's the problem. And I think what we're talking about, and I think I'd like Al to talk about his vision of the different pieces of healthcare delivery science. I think we're talking about tackling an incredibly complex human system. I would argue that places like DHMC are the most complicated human systems we've ever created. Sick people, science, finance, and we haven't treated that complexity with the respect and awe and humility that we need to. It's sort of thought that if you do science, come up with new drugs and come up with new treatments, the rest just sort of takes care of itself. And it does, toward $4.4 trillion, right? So when we've talked to them, they haven't gotten it. So I think our conclusion that we share is that it's the national collaborative. And I think Dartmouth-Hitchcock Medical Center in particular has to create the thread of a great example, right? If we create a great example here, there is no company in the country that's going to say, well, that's great for you, but we like our 9% a year growth, right? If we can create a great example here, it will force the question more powerfully, I would argue, than any single piece of legislation. If we can extend it to the state of New Hampshire, state of Vermont, if we can start doing the kinds of aggressive prevention activities, if we can link these services together, I think that we here could create the example that puts the lie to all the claims that you can't change the system.
Al?
I arrived on November 15th, and as I mentioned, there's no question that I recognize that the center existed because of pre-existing strengths, many of which I didn't know about. So I've spent much of my time listening during this period. but also listening to try and put together a story from what I was hearing from others. And I actually believe that what Jim said is absolutely correct. We haven't had an appreciation for the complexity of healthcare and the need for bringing the very best thinkers from across disciplines together and intentionally connecting them in iterative ways with the very best doers across contexts. From the very best thinkers across disciplines, whether it's management sciences and public health and medicine and anthropology and sociology, economics, you're going to get some innovative ideas. But the very best ideas will succeed in some contexts and fail miserably in others. So unless you build a portfolio of laboratories, a portfolio of contexts, you're going to discard a lot of good ideas just because you didn't give them a fair test. And because the resistance to change in healthcare is so great around fundamental issues like, is it a good or is it an instrumental good? Is the good health or is the good health care? Because resistance to change in thinking about that is so strong, you also need to connect the best thinkers across disciplines and doers across contexts with the very best communicators across constituencies and media. Now, that all came from listening to people at Dartmouth. And I could give you a half a dozen examples, but I'll just point to Elliot Fisher. Elliot was getting lots of questions about ACOs that he couldn't answer. He's the kind of person who doesn't like to be stumped repeatedly. So what did he do? He reached to the middle of the country, to another university, and engaged Elinor Ostrom, last year's Nobel laureate in economics, who wrote a book called Governing the Commons, because he saw common pool resource problems in healthcare related to the structure of ACOs and thought that she might be helpful in thinking through that. And for those of you who haven't figured it out, it wasn't an accident that Atul Gawande went to Macallan. Elliot and others from TDI sent him to Macallan. Okay? So best thinkers across disciplines connected to best doers across contexts, all working with best communicators across constituencies and media will solve this problem.
Other questions? That question is, how do we get involved?
Well, you are involved, even if you don't know it.
Let me try that. What I just gave you was a bit of a story that was meant to bring together the aspirational goals of the 5 domains and the 16, 17 projects that have been referred to in earlier renditions of the announcement of the center. And but it's not enough. I mean, it's what we need to do is to bring the discipline of science to DHMC as an innovation platform. We need to bring the discipline of science to lots of potential doers, if you will, partners. And what I mean by the discipline of science is if there are some of us in this room who never have to defend our status as a scientist. Most of those spend at least some of their time in a wet laboratory, right? But the rest of us in the social sciences and other disciplines, are always looked at askance by those who are at the NIH trough year after year after year, decade after decade after decade. If you ask those people, what did you do today that was science? They would be wrong if they talked about doing something in their lab, right? The science is being able to be disciplined enough to generate falsifiable hypotheses about what is going to cause a certain effect. Okay? We need to get very disciplined in our thinking about the way we deliver care and generating hypothesis after hypothesis after hypothesis about what would be better. A major effort on the part of this new center will be building the methods and the metrics so that we can try things and discard those that don't work very quickly. That's what we need to become as an institution. That's what DHMC. So part of it is getting ready for that. Part of it is being involved we'll be conducting focus groups involving providers as well as patients about the kind of metrics that make sense, about the kind of methods that make sense. So that's one thing to look forward to.
There's clear examples in our organization today with EDH coming on board, our new Epic. Everybody's got a role. How we use that tool in delivery of care will impact on what the cost of care is, and the data we collect in that tool will allow us to evaluate what we're doing. to feed back so we change our care. The clinical pathways that we've asked people to work on, some are working really hard, some aren't. We need everybody's mind in the game. There is no person's position in this organization that doesn't impact on every Sheila we see. It's all of us.
Let me just give you a quick example. So in our drug-resistant TB program, we realized that we had an enormous managerial challenge in addition to the clinical challenge. And so what we did was we asked Don Berwick, current head of Medicare Medicaid, to come down to Peru and to help us turn our little organization, which is really the people who actually provided the care were junior high and some high school graduates from the community that I showed you. So what he did, it was just a crazy idea. He brought Edwards Deming. W. Edwards Deming was the great innovator who brought quality improvement and the notion of Kaizen to Japan and revolutionized Japanese industry. I mean, under his tutelage, Toyota went from making the worst cars in the world to making the best. And there are people right here, like Paul Batalden, who have really pioneered the use of those methods in changing healthcare. So in 2000, I talked to Don Berwick and talked him into coming to Peru. And he brought these little PDSA cycles, short cycles of change, to our community health workers who hadn't finished high school. They, to this day, still operate their institution like that. So every time there is a problem, they start generating hypotheses about how they can do it better. They come up with ways of measuring whether the change was an improvement or not. And if it's an improvement, they go the next step. But what he helped us to do was to implement, in the slums of Lima, Peru, a completely different attitude toward change, an embrace of change, a pride in it didn't matter what it was. One of the problems that we took on was when a shipment of drugs comes from the United States, how do we make sure that they all get logged in correctly? So instead of saying, oh God, we got to log in the drugs, they were constantly thinking of new ways of doing it. And every time they came up with a new way, they were rewarded in some way, not financially, but by celebrating the innovation as something that really helped the overall organization. Now, there's a lot of talk about this, and I know that physicians are often really cynical. Oh God, that that sort of hyper-enthusiastic, improvement crap. But there's a reason why G does Six Sigma. There's a reason why these companies do it, because it actually makes them work more effectively. And I have seen it work in Peru. And the latest project that my wife led in Rwanda was exactly the same thing, to improve prenatal care in rural areas of Rwanda. And same thing happened. These were mostly illiterate community health workers who really got into this notion of turning their little organization into a learning organization, as it's called, and continuing to find ways to make it better. I think that there's no institution in the world that needs that kind of spirit more than hospitals and healthcare centers. And the good news is that here we're not going to give you a watered-down version of it that comes through correspondence courses. We've got the originators right here, and we'll do it in a way that I think could be very powerful. So in that way, sooner than you think, I think every single one of us in this room is going to be asked to engage in this process of rethinking what we do and how we do it.
I know I'm not on the panel, but I can't resist the opportunity to piggyback on some of the things you've said, and to say, for that very great question, if you work at Dartmouth-Hitchcock, you are involved. We have said our focus is on improving the value equation. Our focus is on measuring outcomes and improving them and lowering cost, and the only way we can do that is to transform the way we give care. And that's what EDH is about. That's what we're pushing toward 2015 on. So as Jim often describes, we have an orchestra here, and each and every one of us has a part to play, and that part is on this pathway of transformation of healthcare. So it's just an absolutely exciting time to be here. So we are involved. Any other questions that we have today? Yes, and then I'll go to you.
Yesterday, we had a meeting
Jim,
with...
could you just repeat? This question is about how do we get the right data, and how do we partner with other organizations that are gathering data so that we're sure we get the right data? For example, the state of New Hampshire.
Yeah, I think we have to partner with a lot of people. The notion of the Medicare data has been wonderful because it's one data set. But how do we bring clinical data into that. And the state, we just met yesterday with the governor's staff from Vermont, with Frank. They're looking at us as potentially helping the new governor bring in their single payer system with a new data system. And one of the suggestions, is, what are we going to do for New Hampshire? We haven't had those discussions with Governor Lynch directly, but we're anxious to do that. The number of lives in this region are not that many. We ought to be able to take care of those populations pretty well, better than we are today. And we ought to be able to share resources that are limited for all of us in different ways to achieve that goal of taking care of the population.
Just a couple of other comments about collaborations that were pre-existing before the center. There's been a lot of work using claims data. As you well know, it was invented here in a sense, actually invented in Burlington and then brought here a few years later by Jack in the early 73. There's also been a lot of work going on between folks at TDI and others around the country who are really interested in the interface between claims data and public health data. So Chris Murray, a longtime friend of Jim Kim, trained together at the Brigham, left Harvard and went to University of Washington, and with a $50 million grant, $150 million grant, started a institute for metrics in healthcare, bringing together the clinical and the public health issues. And we're collaborating extensively with them, and that's something that Elliot and others at TDI have been doing. The other interesting thing is that just because of the existence of the center and the evidence, support, and energy coming from the president and provost's office and from the president's office here, when the Hotspotters article came out, there are a whole series of folks from the engineering school, from Tuck School, from the math department, the chairman of the math department, unsolicited, sent an email saying, I want to help with this kind of risk analysis. So the notion that this is for best thinkers across disciplines is really recognized.
The question was, how does the southern region, our partners across the state and states, actually get engaged in this work? And, as we roll out the clinical pathways, that's across the system. As we link ourselves with EDH and have an integrated medical record, we do that together. As we think of the innovative ideas in the Hotspotters article, where do we start that work? Do we start it here in Lebanon? Do we start that in Manchester with different communities? Some of our funding through TDI that you're probably not aware of with CDC and other organizations is actually looking at the health of the population in Manchester, in those most in need, looking at issues like prevention strategies for cardiac disease and other things, and training, teaching people about diet and exercise and wellness. So there's a lot going on that we don't talk about probably, that we need to communicate better, because you are involved, and we need your involvement. We will not be successful without it.
I would suggest, Jim, it's a two-way street. There's a lot going on in the community group practices that has transformed care in a way that we need to infuse in our center in Lebanon. So it's truly a system-wide effort.
If I could just jump in here, I don't want to leave the impression that it's just bringing the discipline of science to healthcare delivery. There is this whole question of qualitative experience and what you'll see. I'm sticking with D's here, but it's the discipline of science, but it's also the discernment that comes from experience. We often think of wisdom and where's the wisdom in healthcare? You got to be old to be wise, right? Or sagacity is if you can find ways for people to readily share their experience, even if it's qualitative, you can build an enormous resource for generating the hypotheses that you're then going to test with the discipline of science. And you heard Jim refer to the case studies that he was developing with Michael Porter and others at Harvard before he came here. We're anticipating the center making a major investment in our ability to develop two-way case studies, if you will. Mm-hmm. The whole purpose is to share information from, it isn't the great professor delivering off of a 25-page single-spaced case the wisdom to the class. It's using social media, it's using interactivity to learn much more quickly about what you all are thinking as we're making this kind of a presentation. So that'll be another major effort on the part of the center to engage everybody here, but also to engage your counterparts in other locations to make their experience and the wisdom that comes from it available here.
We might want to try an experiment, Al. Just let everybody at DHMC participate in one of our cases.
Yep.
We'll teach it to everybody, and then we'll open up the website so that we can get feedback from all of you and interactively do a case together. There's just so many really interesting ways. For example, if you look at Mike Porter's cases, he looks at head and neck cancer care. At MD Anderson, he looks at the Theta Care system in Wisconsin. There's just so many, the spine care center. He actually even looks at our Rwandan healthcare delivery model in HIV care. So one of the things we might do is just do it for everybody, give a sense of the kinds of things that we're trying to get at, and then capture your collective wisdom and make it, again, part of the next time we teach the case. We can do that.
And the other thing is in the National Collaborative, we're working with what we think are some of the best organizations in the country. And what you don't know is every week there's a phone call with those organizations that occurs that nobody misses. And it's been going on with Lisa Weiss leading those calls for months. There's interest in what we're doing here from the best places in the country, and we need to learn from them and bring that here as well. It goes both ways. So there's a lot going on to help the whole community.
Could you repeat that as you
The question is, when is the center going to be open for all of its programs? I think that's a really hard question to answer. There's some 16 or 17. What I described to you is a process of putting together a story from which a strategy emerges, and I've given you a sense of two of the major priority areas. One is developing the methods and the metrics. Another is developing these case study methodology. We're also going to be having a stream of work that will engage the whole community at Dartmouth in allowing Dartmouth to become the convener and collaborator of choice in this area, including among the 5 other following schools, but also to maintain the leadership position of being the first mover. The master's program is one of 7 initiatives in the educational domain. It's going to begin on July 5th. Is that right, Katie? Yeah, it's going to begin on July 5th.
Can you tell me the deadline for application to the program? Application to the master's
The
program.
deadline for there's been it's a 3-cycle admissions process. 1 cycle is over, and there have been 10 people admitted. We're currently turning down 2 or 3 folks for the ones we choose. We're going to have another cycle. We're in the last is March 4th, for the master's program.
It's an exciting group. I mean, we're hoping to have teams from developing countries as well.
Al, Jim, and Jim, thank you so much for being here and for all of